but if it's something like, wait a minute, that doesn't make sense, I'm happy to talk about that. So it was we're going to go over a lot of stuff. We talked about the Cutler Center for Men at Ahuja, is what I'm the medical director of, and we also have a network of providers across Northeast Ohio. And so that's what we're going to talk about today. All right, so please do disclosures. I have no disclosures, right? So learning objectives, we're going to talk about the data and dynamics of men's health, including the gender gap. We're going to think about life expectancy and occupational risk. So we'll just sign up right up the aisle for public health. And we're going to talk about how you can advocate for men. All right, so we know overall, you probably know, even within your family, that men don't live as long as women. Overall, 5 years less, 200% more cancer deaths, so almost twice as many. And men have self-evaluated their quality of life as being less than women. This is a national priority. So this was a bill in Congress that talked about, what can we do to improve men's health. So it's not just a thing. It's a national thing, and we'll learn more about it, really. One of the easy things, men take more risks, right? And this is not like I am particularly not a risk taker, right? I'm not going to jump out of a building. I'm not going to bungee jump. I'm not even going to walk across one of those little ropey bridges. So maybe I'm not a man. Who knows, right? So we say that, in general, we have all these general statements about things. And so don't take offense, but overall, men take more risks than women. Men overall have more dangerous jobs. There is more suicide. And so one of the things we'll talk about today is you have to be deliberate about, particularly in the Board of Health, is accepting a fact as a fact, no matter it may be a hard fact, what I'm saying, for you to take, but this is all statistics. It's all facts, right? And so we have to kind of be neutral. You may have a bias towards something, and then you see this fact and your bias wants you to talk, well, I don't know if I believe that, type of thing. But but generally the things I'm going to present have been facts over time. And I usually show that as well. Men are less socially connected. And so you see that. And so I think I've been married 29 years, but what used to annoy me most is she'd say, well, what are you thinking about? In some moment, right? I'm not thinking about anything. That's my response. And her response is what? Yes, you are, right? Yes, you are, right? But I was simply being not socially connecting, really, right? I was just daydreaming or whatever it was. And so, that tends to be the truth. Less conversation. My mother always started talking to someone and she couldn't stand in a line in a supermarket without talking to someone either in front of her or behind her. I don't think I've ever spoken to anyone in front of me or behind me in the line at the supermarket. So I'm less socially connected as it relates to that. So that part goes. And then 10 doctors, men avoid doctors. They don't really like to go to the doctor. They don't like to when I had COVID back then, my wife saved my life by waking me up and saying, we're going to the hospital. And I was like, I don't want to go to the hospital. Will you leave me alone? You know what I mean? And even though I was a doctor, I was sick in bed. I had been sick in bed for maybe 5 days. You know what I mean? But I wasn't thinking like a doctor. I was thinking like a man, right? Don't take me to, I'll get better. Just leave me alone. And we know all too well how many people were found dead in their bed, because they didn't go to the doctor. And I had a patient, her son took her to the hospital with COVID pneumonia and went home and laid on the couch and died while she was in the hospital. And so this happened. And so it could have happened to me because I didn't, my knee-jerk reaction was, I don't want to go to the doctor. And unfortunately, men have a lot of that. So there was a survey that looked 77%, and I just love this, 77% of men who are married or in a domestic partnership would rather go shopping with their spouse than go to the doctor. And if you're in my marriage, that's a really strong statement, right? But because that, so that's a lot. That just shows you how much they'd rather not do that. 41% were told the child, man, you don't complain, stop complaining, get up. 82% say, they try to stay healthy for their family. So I don't have time. I got to be the breadwinner. I've got to do all these things. I don't have time to really look at my own health. Men are the victims of 92% of workplace deaths. that's a lot, right? 9 out of 10 workplace deaths are men, and these things happen. And what is that? Is that I have a lot of patients from across a number of occupations. I have linemen, people that go up poles, electrical linemen. And I said, do you ever, with accents, he says, if you follow our procedures and protocols, you will not have an accident. So whenever you hear something happen, that person did not follow protocols and procedures. They'll tell you that, right? And so that's back to men taking chances. Well, let's cut this corner. And then that's where workplace deaths come from. Vastly higher risk of being a victim of homicide, 4 times more likely to commit suicide, which should absolutely stop everyone. And by age 100, women outnumber men 8-1. And so I have maybe 10 people over 100 in my practice, and none of them are my oldest man is probably 96. So, and that's in the nursing homes, in my office, that's everybody, right? So men do die younger. So let's look at life expectancy. Overall, this is men and women, this is everybody. Men 75, women 80 overall, right? And so I'm gonna put this up. I've been talking about this for a long time to a lot of doctors. And so your choices here, this is your first test, is African American, Hispanic Latino, white, and Asian American, right? And so who is who amongst the life expectancies, right? So most of the time when I speak, I'm speaking in terms of African American health, things of that nature. So I will spot you that 74.8 is the African American life expectancy. And that doesn't surprise, no one's surprised in here about that. So I want to hear, I'm gonna put you on the spot. Who's 78.8? Yes. Hispanic, okay. Who's 81.9? Asian. Okay. Who disagrees? And who's 85.6?
I think that's the Asian, and I think 81 is white.
Mm-hmm. And who's 85.6?
The Asian.
Okay. Who wants the Asian Americans right? The colors, right? Right. Yeah. No. Anybody disagree? You got? What do you say, John?
Yeah, I think
Okay. What? Who's 81.9?
Yeah.
Okay. Everyone sure? All right. Well, sorry. Okay. 78.8 is black. 78.8 is white, right? 81.9 is Hispanic Latino, 85.6 is Asian Americans, right? And so, like many of you, I thought with minority health, right? I was chairman of the Commission on Minority Health for the state of Ohio, that minorities have all bad outcomes and the majority had best outcomes. And so the reason why I took the job as the Cutler Center for Men, not Cutler Center for Black men, because there's a significant disparity for white men. White men don't live as long as Hispanic Latino men, don't live as long as Asian American men. And what happens with African Americans, we're frequently compared to whites in terms of our disparities, but we really need to be compared to the gold standard, which is Asian Americans. They live the longest all the way around. And you see the difference. It's over 10 years. So this is women and men again, and you can see the difference. White men 75, white women 80. You see Hispanic Latino 75, 82, 68, 76, and 84, 84, 87 for Asian Americans. Right, and so this kind of shows the life expectancy. So imagine having a life expectancy of 87.4 compared to me having a life expectancy of 71.3. That gives me under 10 years. I need to not be here with you. I got like 9 years left on average, right? And so, that's a significant difference versus 87. Oh man, for 87, I might not retire. I don't have to go to Europe yet, right? So these differences are basically listed there. And so this, again, is mind-boggling to me. Again, this shows when people kind of fall off, right? How long you live and what ages you drop off. And so it's amazing to me to be 80% of Asian American women are alive at 80, right? And in my world, 80 is old, right? Particularly since I'm further away from it, right? As you get closer, it gets older, right? But 80% of Asian American women are alive at 80. And that's compared to maybe like just under 50% of African-American women. And so you can see where people are. This is the shortest living. This is Alaskan Native male dying at 80, right? So there's a 12-year difference overall between Native American and Alaskan Natives, the lowest living, and the longest living, Asian American. And so I don't have a slide on this, but if you look at genetic testing and whatnot, it shows that Native American and Alaskan Natives are Asian American, of Asian American descent. And so this all speaks to social determinants of health, right? So that the oldest living and the shortest living are genetically, you almost can't tell, right? And so it's a big difference. And it talks about our potential lifespan of 125 years. Can you imagine living 125 years? That humans should be able to live 125 years under ideal conditions. Janet does not believe that. And the oldest living documented person was 122. So it's not unheard of, right? And so the fact that we are losing 40 years of potential should not be lost on anyone. If we look at the causes of death, and these are all causes, the big tall one, so you can like ignore all cause, but the second one, heart disease, is like right there. That's the number one cause of specific cause of death, heart related. And you see cancer there, and then you can jump down to diabetes, unintentional injuries, suicide, like that. And we'll spend a little bit more time looking at that. And so they've said that technological progress is going to be one of the things that's going to allow us to live longer. And so that's, looking at our genetics, looking at what we're at risk for, really screening for things if you're at increased risk for some type of cancer or heart disease. And then, the amazing things that they're doing with MRIs and all those things in medicine is allowing us to detect things better than we used to. It's like, so you remember they say, are you doing your self-breast exams? No one's ever saying anything about doing a self-breast exam. Please don't do a self-breast exam, right? Get a mammogram, because mammograms can see microscopic things way earlier than you would feel, right? So you shouldn't feel assured that I'm doing self-breast exam. There's nothing wrong with me, like my patients tell me, right? You need a mammogram. And that's why people aren't getting mastectomies. They're getting lumpectomies. They're taking that little part out and going on about their business. If you wait till you or the provider can feel a lump, that's too long. That's too far. And so mammograms is a perfect example of a technology that now is really able to detect things that are so early that almost no one has to have, really deforming surgery. And it talks about future progress related to really genetic influences and epigenetic influences. We may talk about a little bit later. So this next section, let's talk about leading cause of death for men. This is white men. So from going across the top, this is age 1 to 19, 20 to 44, 45 to 65, 65 to 84, and then 85 and over, and then they kind of combined all ages overall. So you can see from age 1 to 44, unintentional injuries, which sort of makes sense, is the number one cause of death for white men. I mean, so that's the accidents, that's overdoses, that's things of that nature. Bungee jumping without checking the rubber closely. Okay, that's fine. All right. And number 2 is suicide, right? Which is also not a big surprise. And you see that from 1 to 19 is 35%, suicide is 23%. And we know those numbers are lower, right, than like the 85 plus. So the pure numbers, so we got a percentage of this, but it doesn't go across. We're using lower numbers from 1 to 19 and 20 to 44. But that's what we need to, our attention needs to be on, these unintentional injuries and suicide. So we are addressing unintentional injuries with our overdose. All of our programs are looking at and trying to reduce overdoses, because that's an unintentional injury. It's not a suicide if someone does drugs and accidentally dies. That's an unintentional injury. You see, homicide is number 4 for white men. And so just kind of keep that in your head. And it's number from 1 to 14, and it's also number 5 for 20 to 44. We see that as you get older. Overall, once you get the full numbers down, we know that heart disease, like I said earlier, is number 1, cancer is number 2. Then there's a jump down to unintentional injuries, which is almost 7%, COPD and things of that nature is number 4, and then stroke is number 5. And so that's overall because of the pure numbers are there. So looking again at unintentional injuries, what's an unintentional injury? Car death, dying in a car, right? Work-related injuries that men take 90% of, right? Fall deaths, rock climbers, bungee jumpers, right? Fires and burns, poisoning and aspiration death, and that's their unintentional, accidental overdose, and then drowning. So those all get bunched together into unintentional deaths. So homicides, 80% of homicides involve a firearm. So when someone kills someone, 4 out of 5 times it's a gun, right? And then the other 1 out of 5 times it's something else, a knife or suffocation, or something like that, right? So suicides counted for more than half of U.S. gun deaths, right? So if there was a gun death, you have a gun, more likely to commit suicide with it than protect your home, shoot someone else. So this is the part where people start rolling their eyes, but it's just the fact. I'm just giving you the facts. That's not, that is what it is. We know when it's suicide death and we know when it's a murder. And it's not changed, right? From 1968 through 2020, suicides have always been higher than homicides, murders with deaths. So when you look at a gun at your home, know that that gun presents a significant risk to someone in your home. I mean, statistically, not anything Greg Hall thinks, right? And my father loved guns, my grandfather loved guns, my brother loves guns. So I'm just telling you the facts. Maybe you might want to hear it, but these are the facts. A gun is more apt to kill someone you know than protect someone you know. Just done that. So we look at leading causes of death for white females. We see same sort of pattern, unintentional deaths, unintentional injuries rather, causing a premature death. We see suicide from 1 to 19, which is not to be ignored, right in that young teen age. So we want to think that overall with women, heart disease is still number 1, cancer is still number 2, lung disease is number 3, Alzheimer's disease is number 4, and stroke. So Alzheimer's disease didn't make that first 5 for men because we don't live long enough to get Alzheimer's disease, right? We're dying of other causes before that. All right, and suicide methods in women, overdose is number 1, and then gun-related number 2. And you see it says hair under there. So a man is more apt to use a gun to kill themselves. Women are less apt to use a gun, more apt to take an overdose. That would be an intentional overdose. And people are still hanging themselves. I don't understand that. There's still CO2 poisoning, and there's still people that jump, to their death. Still some significant number, but overdose is number 1. So if we look at the leading cause of death for non-Hispanic Black males, this is the part that's disturbing to me, is that if you look at the age from 1 to 44, the number 1 cause of death is homicide, to be killed. So I have 3 sons in their 20s. Their number 1 risk for death is for someone to kill them, not kill themselves. You see where suicide is, but their number 1 risk is to be killed until they're 45. After that, we see heart disease. We see, and even homicide made the top 5 list for them. And that, again, homicide was not on the top 5 list for white men or white women, right? So that's homicide is a significant issue. I know you guys are doing this. Again, just the facts, right? So this is an interesting study. Looked at lifetime risk of being killed by the police. I love the police. I have friends in the police. I have family in the police. I'm not talking about any of them. All right, the risk for being killed. And if you look at this risk, the center is it kind of grows from the left and the right. And you guys aren't seeing it, but the female is red. You see it? See it now? Look hard. That's female risk of being killed. And the blue, blue-green, is male. So you see African-American men, far higher risk of being killed by the police compared to African-American women. So many of you know, I grew up in Glenville. I know some women that will kick your butt, beat men regularly, right? Because women can be something, right? But the police disproportionately do not shoot them somehow. right? See Native American, Alaskan Natives, you see Latinx, you see total combined, you see white, and then you see our gold standard in living in these United States is Asian American Pacific Islanders, the smallest risk for being killed by the police if you're a man. And you guys can't even see the little line for women, right? So there's a significant risk. This is just the facts. I don't have more crime. We can go into all that, but this is the outline that's there. I'm gonna dwell on it. All right, leading cause of death for Black females. We see unintentional injuries, right? I'm sure there's some overdoses in there, right? Other motor vehicle accidents, things of that nature. We see homicide in there from 1 to 19. And then it's the fourth cause down from 20 to 24. Then unintentional injuries and suicide. So if you look at that whole all ages again for Black females, you see heart disease, cancer, stroke, diabetes, Alzheimer's disease. We don't see homicide on that list, and that the data we've seen is sort of lines up for that, right? For Asian Americans, since I've been talking about them so glowingly, right? Unintentional injuries, suicide, still 1 to 19, but you see cancer as 20 to 44. Much smaller numbers again, but you can still see the pattern. But see, cancer is the number one, not heart disease for Asian Americans, it's cancer. And then heart, and you see, look at the jump, it's 25% jumping down to 19. So it's not like 25, 24, like it's almost, cancer is more apt to kill an Asian American than heart disease. And that's a lot of that, these are things that go along with what advances heart disease. All right. Hispanic females, you see the same thing, unintentional injuries from, you see homicide for 20 to 44 is number 5 down there. You see suicide as an issue, unintentional injuries. And then looking at all that, see cancer, number 1, right? And heart disease, number 2, stroke, Alzheimer's disease. So that community has a different sort of thing. So cancer screening needs to be more intense because that's what they're more apt to die from. And from 45 to 64, that's the number 1 cause, cancer. So for Asian American men, we see suicide, unintentional injuries are the number 1 cause, and those are still small numbers. But suicide, unintentional injuries, suicide. So I mean, when you're preventing death for someone under 44, that's what you want to think about. And you see cancer is number 3 down there. If you look, again, homicide, 1 to 19 is number 5. And then overall, cancer, heart disease, stroke, unintentional injuries, diabetes, all ages. All right, gun in the house. These are so. If you look at the graph on the right-hand side, it says personally owns a gun is that green. The light green is doesn't own a gun, but someone else in the house does. And then the last one is the net guns in the household. So of all adults, 42% have a gun in the household. That's a little over, almost half, more than a third, right? And the men, 44%, women, 40%. So don't think women are slight. They've got a lot of significant number have guns. Look at the ages, 18 to 29, 43%, 30 to 39, 39, and then 50 and over, 43, 65 and over, 45. So as you get older, more guns. And then despite African American men being at highest risk for being of homicide, number 1 cause of death, look at the number of guns in the house. 49% of whites have a gun in the house or own a gun, compared to 32%. So there's not as many guns in the house, right? And the Hispanic Latinos, 21%. And they didn't include Asian Americans, like they frequently will leave them out of things. And so that's just when I didn't leave them out. They left them out for some reason. Again, look at the degrees. High school or less, 41%. Some college, 47%. Bachelor's degree, 37%. Whatever that means. I don't know what that means. And then look at the region. A lot more guns in the South and the Midwest, less in the Northeast, 27%. And then look at urban, suburban, and rural. Way more guns. Almost 60% in rural have guns. And that's why my grandmother had a number of guns. Do not play with her. Right? Because she lived in a rural area and she would pull it out. Someone was knocking on the door and she wasn't expecting a visitor. Right? And so in terms of men and guns, men are more likely to own guns. more likely to own a gun at a younger age, more likely to have participated in gun-related activities, more likely to have fired a gun, more likely to use a gun to commit suicide. And so that's just the facts, right? That's what it is. So, but men have different needs. They also have demographics. They have their perspective on life, like we talked about earlier, their comfort level in a medical setting. When I was in private practice for 20 years, and I got a job at University Hospital 2 years ago. So I had to go get my blood drawn. So I'm in this room, not as big as this, but it seemed like it was this big. And the lady came to the door, like this lady came in the door and said, "Gregory Hall." And I wanted to sink down further in my chair. I didn't want to get up. You know what I mean, right? Like, why is this woman calling my name? And I don't want to be here. You know, it's just like, I don't want my name hollered out, you know, in a room full of people I don't know. And so that, you know, that struck me. It's like, you know, if someone came and said, "Melanie Hall," she got up and walked to the door. Don't bother her, call my name, right? Right? So it's just like that different perspective of just being in that environment. I don't want my name hollered out. I don't want, you know, I want to kind of sneak in and sneak out. And so some of those reasons are why men don't go to the doctor. There was a study done in 2022 that looked at men's help-seeking behaviors overall. And they looked at it, and they looked at structural barriers, internal barriers, and understanding what men think about doctors and what's supposed to happen at a doctor's office, and then self-care and self-help seeking practices, right? So in terms of what men don't like, there's structural barriers, availability of appointments, right? So I was about to make an appointment to see the eye doctor, right? I'm on my phone. I'm supposed to be promoting men's health. I almost hung up. I couldn't listen to that song anymore. You know, when is someone going to answer the phone? I'll just go blind, right? Waiting. I'm like, you know, I don't want to, this is too long. I can't do this, right? So it's like the availability of just someone answering the phone to make an appointment was make me abandon ship completely. And how many men do you know do that? Protracted waiting times, privacy concerns, people don't wonder about that. And then there are people who want a male doctor. There are men that want a male doctor. There's women that want a women doctor. And I see that all the time. There's Black people want a Black doctor. And people don't know that. I'm looking for a Black doctor. And so I'm looking for a Black woman doctor. You know, so there's those preferences exist. And as the medical director Cutler said, there's white men that want a white male doctor, right? And that's not any more racist than a Black man wanting a Black male doctor. That's just a preference, right? That's just, you're allowed your preferences, right? And so we allow that over time. And so if that's going to make you come to the doctor and that's going to allow you to be more comfortable, then so be it, right? They also worry about fear and embarrassment. Are you going to do a rectal exam on me? I don't want to go there. How many men avoided me? They think I'm going to do a rectal exam, right? I'll just die, you know. I don't want, right? And so we have PSA, which is a lab test that screens for prostate cancer. And we don't have to do a rectal exam to screen for prostate cancer. We just draw a blood test. You should see the relief. Ah, I'm like, well, imagine my relief. I'm saying too, right? And so but that fear and embarrassment, I'm not supposed to be sick. There's an understanding of what's supposed to a lot of men think they're supposed to go to the doctor with a problem. They're not supposed to go to the doctor without a problem, right? And so women know, I gotta get my pap, I gotta do this. It's always, they go without a problem. They've been raised to go to the doctor without a problem. And men, you know, we kind of were took by our mothers to the pediatrician, and then sometime in the teens, something dropped off, and we don't go to the doctor for no reason unless there is a problem, right? And so people don't know, if you're not a doctor, you don't work in public health, that there's screening things that we could do to talk about to help them. And then the relationship. A lot of people don't like doctors. They think they're snobby. They think they know it all. They don't listen. They don't do all those things. Why would I want to sit in a room with someone I don't like them? You know, I just don't like doctors. And people will come in, see me, second sentence they say is, "I don't like doctors." I have to smile. right? But those people happen. I say, I understand. Doctors have done some really bad things, and that's a totally different lecture. But doctors have done some really bad things, and that's why people don't like doctors. That's a whole nother talk. I'll come back from some other time. So anyway, there's a significant need to really let men know that you're supposed to get screened. You're supposed to go to the doctor. That it's not supposed to be distasteful. You should find someone you like, right? If you go to the doctor and don't like them, don't just not go to the doctor. Find a new doctor, right? So we want you to be happy, right? So that's important. So this is where the ideas that came to Dr. Ponsky, Lee Ponsky, who's the chairman of urology at UH, to say, let's set up a center for men, right? Because so we can know these issues and then try to address them. And so this is the Cutler Center for Men. The Cutlers are a well-off family, worked at Eton and University Hospital saved them, and they wanted to give back for saving them, and that they made a generous gift to set up the Cutler Center for Men. And it's really just using common sense, but kind of using the community of men as a way to bring them along. And so what they wanted to do, again, this is Mr. Cutler and Lee Ponsky, is to let not just make a doctor's visit tolerable, but make it nice. You know what I mean? Like, wow, like really looking for how do we make it a wow moment? How is it? Wow, well, that's good. I want to go back to the doctor, right? That's kind of the vision, right? And so we do preventative checkups, we do screenings, we kind of organize needs by decade. And so again, if you look at the teenagers, their number one cause, accidental deaths or homicides. So let's talk about, if you know, my number one cause for death at my age now is heart attack, right, or cancer. So I'm like, listen, if I had chest pain, that's my number one. You know what I mean, right? Let me sit down. I'm shoveling the snow. Let me sit down. I'm having chest pain. I'm gonna die out here in the snow, right? So, because that's my number one cause. So if younger people, their number one cause is accidental death, you may do drugs, but they're doing weird stuff with this marijuana, trying to make it good marijuana. And they put fentanyl on it. You smoking a joint and dead. Didn't even see it coming. Wasn't even thinking about that, right? If you don't know it's a possibility, someone should tell you. And the doctors and nurse practitioners should be part of that team that's sharing this information in a way that you accept it, right? So my first deal when I get a patient is to get them to trust me, like me and trust me, right? Then I can give you advice. You do not accept advice from someone you don't like or trust. Just think about it. No, you can't tell me nothing, right? If it sounds right, I ain't gonna do that, right? But you need someone to like you and trust you. And so that's what we're thinking about in the Cutler Center in terms of providers that are likable, that are advancing information in a trustworthy way so that the patients do better. We obviously have all the urologic things that you need in terms of fertility, which is a big deal. And then dermatology, whole health, talking about salt, you know what I mean, talking about all those things that people don't think about. So who watches YouTube videos? Anybody? Everybody? Mostly, yeah. That's what the data would show, right? So if you watch them cook, I love eat. So you watch them cook stuff. Have you seen how much salt they put on stuff? And half the time, the person will say, "Don't put nothing in the box about all the salt I'm putting there." No, I gotta put something in the box about. That's entirely too much. That's too much salt, right? I went to dinner with a doctor and his wife, my wife and I. We were four of us at a steakhouse. I don't know, I can say it was like Hyde Park Grill or something like that. And our steaks came out. The other doctor came out, took a salt checker, and they salt that already. It's already too much. And I sat there and my head almost exploded when he stopped. Right? And I didn't say anything, but my head almost exploded. I said, "You did not put all that salt on this salty steak." You know what I'm saying? So someone needs, and he didn't think anything about doing it in front of me. You know what I'm saying? And that means he didn't think anything about doing it. If I was sitting with my patients, they'd take this off and put it back, right? Because they know it's a thing. And so a lot of people don't know that is driving up his risk for heart attack, stroke, hypertension, kidney failure, all those things. And so we need to be able to have those discussions proactively. And so Men also seek more than just health care. They want well-being. A lot of men are unhappy. They're stressed. They're they're just not happy with their lives at all. So they don't have well-being. So they want people want to. I just want to be happy. I want to live a long, happy life, and that's a lot of that is there. People want to be in the community. They don't want to have to park and pay for parking and walk 3 miles. They want something that's easy. They need mental health. We're seeing that it peaked during COVID, but it also is not trailed off. That people need mental health, and there's not enough mental health counselors to help. They need help with vocational support. Things. What are you doing in a safe way? My brother worked at a factory. We never wore masks. We never wore. And now his lungs are all jacked up because he bragged about, hey, wear a mask. Oh, yeah, put that glove on for yeah. Right? But you have to know that's not that maybe a macho thing to do, but now he's dealing with the ramifications of not putting a mask on and not doing some of the things that were mandated, and the workplace becomes sort of an unsafe place because of things like that. And so one of the things we did was we looked at what are the generational needs of men, actually more like decades than generational. So as we know, men's in their 20s and 30s, they get an STD or they think they have an STD. They come to the doctor then, right? They come right to the doctor for that. And so, but how do you prevent from getting ones? What type of things do you need to know about? What do you think about? I mean, I've got young men come and get tested for STDs regularly. And I'm like, why do you need to get tested so regularly? Right? What are you doing? And why aren't you using protection? And are you ready to become a father? No, father, you know. And I'm like, well, they're trying to do away with abortions. Did you know that? I thought they were just talking about that. No, no, hello. You're going to be a father because, this is going to be a big, horrible mess. And you don't even know. So these things need to be talked about to 20-year-olds and 18-year-olds and things of that nature, and a trusting environment where, I don't do it the first visit, but when they come back, I'm dead on it, right? And for the second STD test. In the 40s, midlife crisis, as you get older, the hall's all prematurely gray. And so when I was 42, I was graying, early 40s. My aunt was gray at 38. That's what we do. We keep our hair, but it goes gray, right? And so it's like, so that was like, I don't have black hair anymore. I'm 42, and do I start dyeing it, which I'm not competent at doing that. I'm just I'm not, you see how much jewelry I have on, nothing. So I'm not thinking about, you see my shoes, I'm not that way. You know what I mean? So I'm not going to dye my hair. I'm going to be the person that has the line of gray, right, with the black. Fine. And so, but those things happen what I'm going on, your kids are getting older. What advice do you give to them? Some people are starting new businesses, and so they need advice. And a lot of people in their 40s have had a job and like, I think I want to work for myself. And that happens in the 40s. In the 50s, you have to deal with the kids being gone, parents getting older, the death of a parent, all those things, 60s, and so on. And so as you get older, we try to offer things that will help them in the decade that they're in, that tends to show up. And so we're deliberate about that. But if we can diagnose people early, intervene appropriately, and we can save more lives, then we're sure insurance companies are going to help support us. The people are going to come support us, and it'll be an environment that will be just a win-win all the way around. So we have 4 areas of intervention. Transition care, some talk called the boys to men, where we're taking teenagers and getting them used to going to the doctor. So when I had a physical, when I was going off to college at 18, that form had to be filled out. And I didn't see a doctor again until I was in my 30s, right? And that happens. I get sick, I got better. I mean, no big deal, right? And so, but we're trying to break that. That's true for so many people. So that when you're at 16, 17, you're about to go away to college, get that now. We give them cards, so we can do a virtual visit while you're in college if you have any problems. You can still go to the college person, but if you need me, we can do that so we can establish this relationship for the long haul, right? Because if you start these practices early and these discussions early, you can have an intervention. So like for many of us, it's just too late, right? But if we can do this next generation, we can decrease the cancers that are found in advanced stage. We can decrease the heart disease and all those things, and make sure that The Joe team is like a support team that helps men make appointments. So with me about to hang up with the eye doctor, I would just say, Joe, I need to see an eye doctor. Fridays are good for me. And then Joe will make the appointment and call, say, we got Friday, October 3rd. Perfect. So that takes the men out of it, right? But the appointment said, if I cancel, you just call Joe and cancel, he'll make another appointment. If I get a CAT scan, you know, I've had people, I get order a CAT scan, they show up a year later, oh, I never got that. Yeah, well, Joe makes sure that they get it, right? And if you don't get it, we're gonna call and make sure you get it. So that Joe team is critical. And then the customer experience, like what's it like? We have a pool table, we have a foosball table, we have big screens on ESPN. So we are really delivered. So when you go and wait in the waiting room, we got Starbucks coffee, we're ready to make you your most comfortable because we know you don't want to come there, and they have a great time. So this is the boys, the men. We talked about these extra programs. We had a jazz night. So we try to actually have social events with our patients that are members, right? So we had a watch party where the Browns beat the Ravens. Remember when the Browns beat the Ravens? The crowd went wild, right? At the end, that was probably our last good game, but we had that up at the Cutler Center, and it was very well received, right? And so then we had classes for all sorts of things: grandparenting, boot camp for new dads, infant care, you know, legal things related to things. I still don't know whether you should get term life or whole life. No one ever gives me a clear answer. The term life people want to sell me term life insurance. The whole life people want to sell me whole life insurance. But what's better? Does anyone know? Term. Okay. All right. Well, there you go. Well, but we want to be able to answer some of those questions for men as they get older. This is Randy Vence. He's the medical director of the minority men's health aspect of the Cutler Center, and he's out in the community. He's a urologist specializing in cancers of the kidney and prostate and whatnot. So there's a minority men's aspect of the Cutler Center for men as well, and he's nationally known, and it's important. There's the Joe team, and then we have a provider network I talked about all across Northeast Ohio. So I see patients on Monday at Hoosier with their doctors on the west side. There's people on the south side and Solon and whatnot. And so it's important that we get that. So we look overall distribution of causes of death. You see there, heart disease, and these are all races combined. And you know, so we want to think about what you're doing as a board of health is things you can do to prevent hypertension. It's going to help all the things related that come from hypertension, just heart failure, stroke, heart attack, things like that. Cancer is number 2. If you want to get the low-lying fruit, the number 1 cancers: lung cancer, colon cancer, breast cancer, things of that nature, right? And then we need this rising number is unintentional injuries, and you all know what that is. That's accidental overdoses, right? And these are all the rest. So can we narrow the gap? This shows you right here. This is the gap for the Netherlands. There's like less than 2 years, like a 19-month male female gap in the Netherlands, and then we're less than 4 years. And you see the gaps are even worse. Look at Mexico and and other places. So it can be done because we know because it's been done, right? So again, this is looking at the differences in terms Asian Americans, again, the gold standard for living, and everyone else. And you can see that there's a difference. Asian Americans live longer across all the causes of death. So it's not one thing. And you saw risk for homicide, risk for suicide, risk for accidental overdose. All of those things are play into it. So nearly 90% of the Asian white life expectancy gap is attributed to Asians just living longer no matter what, right? But we know they can do it. It's not necessarily genetic. It's partly cultural. It's partly activities. So it's a combination of things, right? But we can do it. And then overdose will be, I want you to talk about this. I don't want to bore you too much, but I've got the standard slide deck. So the difference I was showing this on here is that Asian men live longer than white women. So when you look at the cause from flu and all that stuff, I'm going to the previous one there. Heart disease, you see male and female white Asian males live longer than white females in terms of heart disease, in terms of cancer, in terms of cerebral vascular disease. So that's just showing that this male-female gap is not necessary. It's not ingrained because we have Asian American men doing better than white women, right? And so that means that we have a ways to go for everyone, and that's crazy, right? And so again, one clear example is obesity. This is obesity overall in 2019, 2020, basically. And I'll show you, this is non-Hispanic whites. The darker it is, the more obese people are, right? This is Hispanic Latinos. This is Native Americans. This is blacks. Look at that. Darker, more obesity. These are Asian Americans. Isn't that crazy? So just another example of the things you can do. And so this is just showing obesity by significant difference. And we know the things that drive obesity. And these are all the things that are obesity related: heart disease, high blood pressure, diabetes, stroke, sleep apnea, all the gallbladder disease. These are things associated with obesity, and it's hard to talk about, but it's the facts, right? However, some people, I get that, but I don't get the gun part. Well, you got to get all of it, because it's just the facts, right? So if we're not concentrating on obesity, we're missing an opportunity to do something about all these cancers, and we saw that cancers is the #2 cause of death. We've overall done well with decreasing cancers. And so these are the things that contribute to shortened lifespan: smoking, job-related, obesity, accidents, cancer, heart disease, suicide. Those are things that those are low-lying fruits. If you address those, you can make a difference, right? Within cardiovascular disease, stroke, cancer, all those, right? Smoking is a big difference. Obesity is a big difference. Alcohol. You can't just decide alcohol is not a fact, right? It's related to that as well, okay? So people are succumbing to the same diseases, right? But the secret is what those differences and being patient-centered. Like, what if you see a 35-year-old black male, his highest risk is to get shot. You see a 35-year-old white male, his highest risk is some accident. It might be an accident overdose, right? And these little things can make a difference. So you want to use data to confirm problems, not just what's politically acceptable. I mean, this whole gun thing is a hotbed political nightmare, right? But it's a fact that is really contributing to a lot of people's deaths. So let's take a team's approach. And I'm going to take some questions at that point. I know that was a lot. It was 111 slides. Can you believe it? Woo, I'm sweating on the inside here. So do we have any questions? Mm-hmm. Mm-hmm. Mm-hmm.
Like, it was all great, so I just wanted you to that.
That's great. We got everything but alcohol. But that's sports bar-ish, right? Yeah, the snacks. There's a, well, thank you. Well, that's being, we're deliberate, and we're the only men's place really in Northeast Ohio that's not even really in Northeast Ohio that's doing it. The people that have that location is just designed to do what it's supposed to be doing, make people feel comfortable, make them not feel like they're gonna. And then when you're waiting, right? It's one thing to wait and stare at people and not look at the TV and they got General Hospital on, versus you can play pool. I've had patients take the next patient. I got to finish this pool game, right? And so I've had that, and so they're really feeling comfortable there. Yes.
For engaging general public going to health fair or at the fair booth, they're walking up. When the common cause of death for people there, are either homicide or suicide, what would be a good thing that we could say public health wise to them to address, other than check out our website? What else would you suggest there?
Well, I speak to young black men, right, and I drag it out. Like, what's the number one cause? What's your number one cause? A car accident. They list everything but homicide. So again, if getting shot is your number one cause, you're gonna look out for guns. Right? You're looking out. If someone pulls a gun out just to show them I'm leaving the room, and I'm not saying I'm in a hostile environment or anything, but if people like guns, so let me show you this gun I got. Where's your kitchen? Right? because I'm getting out of here. You know, so it's like because I know I'm at risk for that, right? And so that's what people don't know that's their number one. They think they're going to die in a car accident is going to be their highest risk for dying when it's not getting killed, right? And that in car accident is not even way down on the list. You know what I mean? So I think awareness is what I try to talk about. Awareness about minority health, right? I thought minorities had all bad outcomes. The majority has good outcomes, but that's not true, right? And so you want to have a targeted, you know, Asian American men are not at risk for getting shot by anybody, right? So what you want to talk about cancer screening, maybe what you have anyone with cancer in the family? So those sort of questions will come out of me because there's evidence that there's different risks as it as related to that. Yeah. Mhm. Mhm.
There's several men in my family. Can you talk about like the availability of doctors, waiting times, things like that? And then how would I get them engaged?
Right, and so the question, I should repeat it for the people in Meats land, is related to doctor availability and things of that nature. And so it's not great, right? It's you have a little bit of a wait to get in, like to see me. I'm probably booking in October or something like that, right? And so it's always an issue with trying to get in doctors. But what we can say is that if there's a problem and you're a member, you can see me tomorrow, right? One of my patients is a Cutler Center member and they have a problem, the Joe team will squeeze them in to see me. But if there's someone you've never seen me and you're trying to get an appointment, it might be October before you can see me. And so, and that's because we're popular and people are signing up and they're telling their friends. And I don't just see men, I see men and women. So I've got a ton of husbands and wives that are coming in, and they still see me at the Cutler Center for Men. And women love it. You know, they love that environment. I also have an office in Richmond Heights, and I have women who would prefer to come to the Cutler Center for Men than go to my office in Richmond Heights because they like the environment as well and the customer service and the Starbucks, you know what I mean, all those things. So I think if someone wants to say the key is you can go online, if you Google Cutler Center for Men, there's a register and you can sign up the men in your life. I also tell them 90% of my patients, maybe 80%, are escorted by a woman, right? Their mother, their sister, their daughter, you know, women drive all that in terms of health for men. And so there's women signing men up for the Cutler Center for Men, and that we encourage that, right? And then, but it does take, for some women, it takes a weight off of them trying to talk them into doing this and talk about that. Some of them have to come into the exam room. You know what I mean? He's not going to tell you the truth. I'm here, you know, I'm sitting here, right? He said, you don't forget what? You know, so everyone's welcome in there. So if you go to the Cutler Center for Men, Google that page, it'll say register, you register, then someone from the Joe team will reach back out to you and they'll make you an appointment first available for primary care. And they'll also help you make specialty appointments and make you appointments for anything that we order that they need. So I would encourage everyone to do that. Yes. Say it a different way.
So like some examples of how we.
Well, you can sign them up, number one, because people do that, right? They sign them up, and you can bring them. And that's with sons, you know, I mean, I've got a lot of 18, 19-year-old sons their mother brought, and they're like, he's cool after they, you know, they talk to me, right? So now, I tell them, you know, I'm not talking to your mother about anything. You know, this is between you and me. I didn't go into pediatrics. I'm not talking, even though your mother brought you. I'm not debriefing her on the visit. I'm not talking to her at all, right? And so you would encourage them that we're really trying to deal with men, you know what I mean, and in a way that kind of babies them, you know what I mean, and that maybe you don't want to tell them that, but the environment's really cool. They're going to have a good experience. We're deliberate about them having a good experience, and And that, and they prevention, like this is what public health is about, prevention, right? And so I've talked people, I told a guy who smoked Black and Miles, he should stop smoking. He looked like he wanted to fight me. Well, you can't tell, I'm a grown man. You can't tell me what to do. So I'm like, well, no one's ever told you smoking is bad. He never heard. He didn't know smoking was bad for him. As much as we do, right? And we think there's people that are missing those messages, right? And so I was the first person that told him that he shouldn't smoke. I then apologized because that was me. That was my problem. I didn't read him as someone who didn't know that. And he took what I was saying and trying to tell him what to do. You a grown ass man. Right? You know what I'm saying, right? And so I had to readjust. It's like, I apologize. That went poorly. You know what I'm saying? So smoking's bad for you, right? It causes cancer and heart disease. And I go through all those things. So education and health literacy is really people. When you bring up people's literacy about their health, they do better. I'm eating more vegetables just as I learn more. You know what I mean? I'm not a done deal by any stretch of the imagination. So when people learn more, they find out, they tell them, your number one risk of death is getting killed. If you're on Union, that's probably not a hard message to accept. But if you're at Mayfield Village, really? Yeah, you're still highest risk is to get killed. Okay, well, if I feel like I'm in the wrong place, I know this is where I'll get killed. You know what I mean? So it's just education and health literacy makes a big difference. Yeah.
So one of the things that I know just from research that I did in my doctoral program is around the socialization of men. So you talked about like masculinity, so things like toughness and self-reliance, those types of things that often mean that men aren't help seeking, that they are taking risks and things like that. So how do we start, what are your perspectives about how do we start to socialize boys, right? So that before they become men and don't go to the doctor and all these other things,
right.
How do we start to sort of change the ways in which boys are socialized to be men so that we can, alleviate some of these barriers that we know?
Yeah, I think a lot of things are these multi-generational things. I was laughing. My wife is a nurse, and her mother was her mother, right? And so she gives birth to our son, who's like 28, little Jesus, I call him at the time. And my grandmother my mother-in-law wanted him to eat some real food. She's babysitter, right? So we only did so much, But my wife was like, she's gonna breastfeed him in this long, and then we're gonna do that because she's gonna do it exactly as it's supposed to. And her mother she was beside herself. He needs some cereal, he needs some food. You ate food, so it was like this multi-generational thing. I raised you and your brothers and sisters. I don't know who you think you are, but so it was a big deal. But this cultural thing. So my wife we had to like say, let's not have any cereal. She didn't bring you cereal, did she? You know what I mean? Like we had to work around it to know what's right and then say, let's put these things aside. You know what I mean? A lot of these flawed perspectives that, man, obviously if we're not living as long as we should be, our perspective is flawed, right? And so if we start talking about this in a group and saying it's okay to talk about your prostate, it's okay to talk about erection problems, it's okay, all these things happen, and it's like, wow, that's happening to you too. It's like everybody in here has erection problems. You know what I mean? It's like, oh, so that helps people open up. They thought it was just them. And so we have to be able to talk to people about sexual health and about protecting themselves, about fatherhood, about what sex is for. All those things you have to have those hard discussions. And from a generational standpoint, some of the older people are in the way. You know what I mean? Of their old ways. They live that long. Even though there's a whole bunch of dead people they know, right? I hear, and so those perspectives are not good, right? For that sleeping with babies, you guys know about all the people that still sleep with babies and all the issues. Like you've got to not do that. You got to, well, he's crying. You come over and no, you stop sleeping with the baby. You're gonna kill him. I mean, and you all know me well enough. I do say that. You know what I'm saying? But it's like you have to be able to I'm a trusted person to them, so I can say stuff like that, right? I can't just say it off the street. right? But it's you, so that's why, to this lady's point, you can bring your hard-headed brother, husband, son to someone who can help, that you can't tell them anything, but a professional can hopefully earn their trust and be able to tell them some things. And so that's important as well. Yeah.
Go in and over the web, do you think that's helpful in a situation or getting?
Well, I think it's just what it is. I don't necessarily, it's not the low-lying fruit in terms of harmful or helpful. You're thinking about like all the erectile dysfunction things and all that stuff. Yeah, I mean, I do not connect well with people through the screen. I don't. And from my perspective, I don't know what they're thinking, you know what I mean? But I'm not getting what I get in person. So if I know you already and you got COVID, then let's do a virtual visit, right? I'm happy to do one. But if I don't know you, I don't really want to get to know you that way, because it impairs me, my ability to do anything. The conversations tend to be shorter, the visits shorter. It's just awkward. They don't know how to point a daggone camera on their face, so I'm looking at the light above them. It's like all these little dynamics that makes it hard. It's like, will you move that? So I don't think that that's fun in that sense. But a lot of these medicines are not harmful, so they're not. If they want to go online and get Viagra, go ahead. You know what I'm saying? I think that's not. I'm not necessarily think that's bad, but because there's nothing that I don't. Pretty soon it's probably gonna be over the counter. You know what I mean? Because there's not much that really goes wrong with that. But just knowing that men should know that they need to go to the doctor at least once a year for a preventative check. There's skin cancers, there's all sorts of stuff. And so someone needs to come and look, and if you got something growing on you, point it out. I'll tell you whether you worry about it or not. And we found skin cancers. Black people think they get less skin cancer, but you'll be found with more advanced skin cancer. Yeah.
Sorry, I didn't mean to.
No, go ahead.
Mine is kind of slightly unrelated, but I thought it was interesting earlier on there in a slide, there was a mention that infant mortality rates were also higher in male infants.
Yes.
That was really interesting. I think it speaks to some sort of like deeper systemic thing and how just male bodies are treated medically. And I wondered if you could give a little bit more insight.
Yeah. And you're right. And that's one of those, wow, things that, like, from before birth to death, men are at a disadvantage. Even miscarriages are more apt to be men, and I don't know, what I mean? The answer, certainly you don't know what the sex is of the mother, whatever it is. So it's not like you're treating an unborn baby in a different way, but that's just a disadvantage, that we're there. But once they're born, to talk about, what you're talking about, as soon as the little toddlers are there, they're treated different than the little girls. And some of those things disadvantage little girls. The reason they have girls' schools and boys' schools is because girls are disadvantaged around boys. I mean? They're discounted, and I mean? They're not encouraged by the teachers of whatever sex. I mean? And so boys get more attention. So a girls' school can concentrate on the girls becoming their best thing. And that's just the fact, right? And so there's advantages, and then there's disadvantages, and all that is about how our culture treats, and how Asian Americans somehow don't do as much of whatever that is.
Like you said, they feel like the younger person in that position be as the older person to the younger people.
Way more advice. Yeah. So he was saying that sometimes younger people don't accept advice from older people because they think the older people are stuck in their ways, right? And I've seen that. To an extent, you're right. And that's, you know, I've seen that to an extent. You're gonna be of a certain age, um, you know, whenever you are. Like I was a young doctor at some point, right? And now I'm an old doctor. And so it's one of those things that sometimes you just like you might have an uncle that I can tell him anything, and you know, he listens, and he's more like me than my father. You know what I mean, or whatever, right? And so I think there, you know, if you have an old person who's looking at the chart and not thinking about you, not worried about what you think about them, not really trying to impress you and have you have a good visit, then those are all barriers to that connection. If you have someone like the kindly uncle who's saying, "I understand, I used to be your age. You know, I went to Empire, I went to Glenville." You know what I mean? So that I lived on St. Clair. That breaks down those barriers, you know, so that okay, well maybe you do know. Or you know, or I have a son your age. Exactly. And you know what I know what they do. You know, like you're spending too much time playing video games. You know, so that's not a I'm like, they look at me like, "You been over my house?" I don't have to come over your house. It's what all of you do, right? And so it's like, but that's not healthy, right? We're going to see video game health problems, you know, 20, 30 years from now because people hadn't exercised at the times when they could have. So it's yeah, you have to have a wide range of people, and some people may want a younger person. You know what I mean? If people have preference, and then you just find one. You know what I mean? We want to have doctors to meet whatever, you know, they need. Thanks for the comment. Yeah.
I think one of the things that I appreciate most about the data is making the case for men as a health equity issue. I think oftentimes, you know, from my own experiences, it's been hard to make that sell to people that this is a health equity issue because, right, men have all the power traditionally in society. And oftentimes when we think about health inequity, it's usually for marginalized communities. And so I'm wondering if you just have any other thoughts or suggestions about ways in which we can continue to sort of build this conversation in a larger arena for why men's health is a health equity issue, given sort of that, you know, paradox, I guess that's the word I want to use, for, you know, power and privilege, and yet having worse health outcomes relative to women.
Right. I think again, people being aware of it. I mean, I've spoken all across the country. I mean, white men think they live the longest. You know, and then you don't live longer than Asian American, you know, than Hispanic Latinos, and Hispanic Latinos really that's like wow, really, you know, but no, right? And so I think awareness. There's this thing we all I don't know who we are, but we all kind of hide behind. We're still comparing African Americans to whites. Whenever we're gonna talk about health disparities, we're comparing African Americans to whites. Why? I don't know. I don't have the answer, right? But that's what they did with me. And you should really be comparing them to Asian Americans who are dusting everybody. You know what I mean? In terms of life expectancy, in terms of habits, eating habits, in terms of exercise, in terms of smoking rates, in terms of alcohol consumption. And so when you see that gap, that's the ones worth spending time on.
Someone asked the question online of what is the best way to get flyers that they can share at the John Glenn Center. So I guess maybe flyers about.
Yeah, if you stop by the Ahuja, it's in the Drzezinski Sports Complex part of Ahuja. So don't go in the main door of Ahuja. Go in the Drzezinski Sports and then go to the third floor. One of the Joe team will meet you as you get off the elevator, and they'll help you with whatever you need. Very good. All right. Well, thanks so much. I appreciate you. Thank you. Oh.
Sheet that's right there behind Joe. If you will do that. Find it here really quickly, Dr. Hall. Also, let me share this with you all really quickly. We have an evaluation, so we always want to know just how we can do things better. If there are other health equity focused
topics or things that you all want to cover, please let me know that in the evaluation, and I'll also send this out via email as well so that you all can have that. And then, oh, did I share this? Oh, sorry, I didn't share this with the folks online. Sorry, y'all online. I thought I shared it. So that's the evaluation there. And then also our next brown bag lunch is going to be on July 11th. So just in about 2 weeks. And this one will focus specifically on allyship and a little bit around privilege as well. So hopefully we'll all see you there. You can register using that link there. And again, I'll send this out as well. But thanks for coming. Have a good afternoon.
Yeah, they're just sitting out.